Hello everyone, and welcome to our webinar, Remineralize and Prevent Caries with Varnish Technology, the latest offering in our dental industry-sponsored webinars. Many thanks to 3M for graciously supporting this educational initiative. My name is Victoria Luck, and I'm the Manager of Professional Development for CDHA. I'm delighted to be your host and moderator for this evening's webinar. The webinar is designed into two parts. We will begin with a 45-minute presentation, directly followed by a 15-minute question and answer period. To allow for an engaging and interactive webinar experience for all, you will be given the opportunity to answer some polling questions. These polling questions will pop up at different intervals throughout the presentation portion of the webinar, and we ask that you respond to them as they appear during the presentation by clicking the radio button next to your choice. If at any time during the presentation you experience technical difficulties, such as disturbed audio or video, please call our support team at 1-800-267-5235, extension 500. The number is on the left-hand side of the screen near the bottom, should you require it later. Just to get a few things out of the way right at the beginning, Irene, our presenter, receives compensation for lecture presentations from 3M, which excludes the creation and development of learning activities such as this webinar. All ideas are presented based on evidence-based science and of the opinion of reference resources. This learning activity has received financial support from 3M in the form of a speaker honorarium. I'm pleased to introduce our presenter for this evening's webinar, Irene Iancu. Irene graduated with honors from the Dental Hygiene program at Oxford College in 2007. Since then, she has explored various aspects of dental hygiene practice, ultimately finding her passion in orthodontics. Irene embraces lifelong learning and has completed many professional development courses which assist her during her many speaking engagements. She uses creative teaching methods to engage her audience in a friendly and open learning environment. While not lecturing, traveling, or working in private practice, Irene is an avid photographer, taking her camera with her wherever she goes. The learning objectives for tonight's webinar are listed here. Over 50 years of extensive research has consistently demonstrated the safety and effectiveness of fluorides in the prevention of dental caries. Professional fluoride treatments have changed over the years, giving practices many treatment options from which to choose. Currently, the evidence-based choice of fluoride delivery is a varnish treatment, which results in less fluoride ingestion and allows for a slower release of fluoride to the tooth surface, aiding in remineralization. So without further ado, Irene, take it away.
Thank you so much, Victoria, and such a warm welcome from everyone. I'm so pleased to see these numbers rising. So far, we have 195 participants, and it just keeps getting better and better. So thank you all for being with me here today. As we get started in our lecture and our presentation today, we're going to go through a few things. But what I want us to focus on is one thing, and I really like this quote, Greek philosopher quote, that the only constant is change. And I think we can all associate that with dentistry. The things that we do today are not quite the things that were done 10 or 15 or 20 years from today. And as we move forward, those things will also change and improve with time. So I really want that to be our punchline for today, that the only constant is change. So our time today will be spent focused on four major principles, really digging into the prevention of dental caries. Because prevention is the focus of today, yes, and also the focus of every day when we go into private practice. So it's really important for us to use the tools that are available to us and the key components to kind of action plan. And we ought to use these prevention tools with our clients. We're going to do a quick review on where decay comes from and how caries are formed and the key factors that contribute to client risk factors. Breaking down etiological factors and identifying how dental caries process is a multifactorial and dynamic process. Then we'll close with an introduction to the CAMBRA caries assessment method and how to implement that into our everyday dentistry practice. I found these interesting stats and I love to share them with you. They're kind of shocking and it just quantifies how the value of some Canadian statistics are associated with dental disease. So it's interesting that we can see here that 57% of those around the age of 11 to 12 years old have had a cavity. And of that, 59% from 12 to 19 have had some form of cavity. 96% of Canadian adults have had a cavity. So those are big numbers. When we estimate the number of school days that are missed from children of that age, you'll see that 2.26 million school days have been missed of kids with dental decay issues, and 4.15 million work days are lost annually due to dental visits and sick days. So according to the Canadian Institute for Health Information, severe tooth decay is the leading reason for Canadian preschoolers to have day surgeries this year. So when we talk about Caries 101, what we're going to look at here is how it's preventable, yes, but also the factors that attribute with this caries process. There are 4 things that are important for us to consider when it comes from having a healthy mouth into going into demineralization and dental caries. So the 4 things that are required for dental disease and dental caries, the first thing is plaque and bacteria. The second is reaction with sugars. Third is creating acids. And the 4th is demineralization of enamel. So this is how the tooth goes from being in a healthy state to an unhealthy state. And in turn, there are ways for us to remineralize the tooth. So we can all attest that we no longer have to consider that caries is something that's not preventable. We can definitely prevent dental disease, and we can help remineralize those teeth. And how do we do that? So first, we have to mechanically remove that plaque and bacteria. The second thing we have to do is start remineralizing. So how do we do that? We use salivary stimulants, fluoride, calcium, and phosphate. So you hear me talk about fluoride, calcium, and phosphate today because those are the 3 main ingredients that assist our teeth from going from a demineralization to remineralization. So you can see it's this constant tug of war, this back and forth between bacteria and sugars, saliva, and fluoride. And that poor tooth sometimes doesn't know where to go, which side to go down. So this is what we're going to be focusing on today, really reversing by removing that plaque and bacteria and remineralizing the teeth. There are 4 key components that are required to ultimately lead to demineralization and decay. And we're going to go through each one of these individually. So the 4 things that are required, and I kind of have them as petals here of a flower, you'll see the first one we'll discuss is microorganisms. The second one is the tooth. Third one is sugars. And the 4th one is saliva. So if you have all of these things in the negative, if something is going wrong with all 4 of these things, you'll start to notice white spot lesions, early signs of decay. And those white spot lesions, as is depicted in this circle here, can go one of 2 ways. It can remineralize, or it can continue to demineralize. And if that demineralization continues, then that's how we get decay. So let's go through each one of these guys individually here. Let's start with microorganisms. So as we talk about microorganisms, we focus on 2 major bacteria, 2 main bacteria that are the biggest contributors to the dental disease process. Now that forces us, this focus is not for us to memorize the bacteria like we did in dental hygiene school. Our focus is to realize that certain things promote bacterial growth. So natural foods can also promote bacterial growth. Statistically, they say that there's about 100 to 200 species that may live in your mouth at any point in time. Individuals that practice good oral hygiene might have 1,000 to 100,000 bacteria living on the tooth of each surface, while people that have maybe less cleaner mouths, that ranges between 100 million and 1 billion bacteria. So the first bacteria we're going to talk about is Streptococcus mutans, and we know this bacteria can attribute to lots of different things. Where are they found? So the first place that we're going to look for these bacteria is in pits and fissures and crevices and areas that are hard to reach. And they're most commonly found in adults than they are in children. And they're definitely acidic microbes. And why? So what does this bacteria do? Well, it uses sucrose to produce that sticky substance we all know as plaque. It turns fermentable carbohydrates and dietary sugars into lactic acid, and it's equipped with receptors to improve that adherence to the tooth. So it can really get where it wants to go. Now, how do we prevent this from happening? Lots of different tools that we can use. Fluoride is number 1, and it inhibits all of those effects. Chlorhexidine helps to reduce that population by interfering with the adherence. And then we can use naturally found substances like xylitol to help increase salivary flow, which will then decrease the S mutans in plaque. We can use teas like oolong tea, green tea, black tea, tea tree oil, nutmeg, turmeric, and licorice root. These are all natural substances that are also known to assist with this bacteria. The second bacteria we're going to talk about is lactobacilli, and it's the opposite of the one we just talked about in terms of where it's found. So where it's found is most commonly in children than it is in adults. In children, it's right on the coronal surface, and in adults, it's more adhered to the root surface of the teeth, and they are also acidic microbes. They're largely found in saliva and in contact with biofilm, and they also turn fermentable carbohydrates and dietary sugars into the same lactic acid. They produce hydrogen peroxide, which is different than S-mutans, and it inhibits that growth of Candida albicans. In addition to all of the natural remedies we just discussed, lactobacilli is also really good if you would like to treat it with probiotics, binding the teeth, which secretes antimicrobial substances and reducing the inflammation in the oral flora. Iodine has also been known as a study in children in early childhood decay. So we talked about the bacteria, now let's talk about the tooth. There's 6 common places on the tooth where these bacteria will be found and where decay starts to begin. And the occlusal surface is the first place we all start to notice, especially those deep pits and fissures, so it's really important for us to treatment plan whether sealants would be a good indication. Intraproximal, so tight contact, large embrasure spaces, and over-contour teeth, restoration margins, overhangs, beneath bridges, gingival margins, around inflamed tissue, bulbous food retentive margins, on root surfaces, and in edentulous areas, missing opposing teeth, specifically those that are holding clasps for dentures. So although we know that there are many different types of sugars, and clearly we don't need to remember where they all come from or how they all react in the body, however, it's important for us to be able to identify a select few. I find this works really well for me when I'm considering my nutritional counseling and determining if decay is attributed to the high intake of dietary sugars. So we know that certain foods are highly acetogenic and some are low acetogenic. For example, aciduric bacteria have the ability to survive and continue to reproduce in an acidic and a low pH environment. The acid is mainly, again, from fermentable carbohydrates, lactic acid that converts into the mouth it converts the mouth from a neutral pH to a more acidic environment. So when we look at the sugars, what I want us to look at is these 3 spectrums. So monosaccharides, disaccharides, and polysaccharides. So what we're going to look at is what kind of foods that we normally ingest will have these types of sugars. So typically you'll find monosaccharides, fructose and glucose, will be found naturally in fruits and vegetables, legumes, dairy, and meat products. And the same with our disaccharides. So you'll find the differences in beet sugar and cane sugar, some fruits and vegetables, mainly in mammals, milk, barley, and malt sugar. And our polysaccharides are plant-based, like root vegetables and cereals, breads, potatoes, especially when they're cooked and dry crusted, and they definitely store energy from glucose. Saliva. Saliva has many functions, as you can see on the pie graph on the upper right. So if we kind of go around from right to left, you'll see the first blue section there is lubricating oral tissues. We know that the mouth is supposed to be a wet environment, not a dry environment. It assists in digestion by incorporating our salivary enzymes to break down food. Antimicrobial, it's cleansing. Maintaining calcium and phosphate. So again, calcium and phosphate is going to come up again. And acid buffering. Acid buffering. So what does acid buffering mean? So every time we ingest, so I want us to look at the chart on the bottom left here. So if you look at the pH chart on the bottom left, where my arrow is right here, you'll start to notice it goes from an 8 all the way down to a 3. So that's the level of where pH in the mouth stands before and after we eat. When you look at the little red line here, 5.5, 5.5 pH is where enamel starts to demineralize. So as you can see, this, let's say, is a client that I'm doing my nutritional counseling for him. So this client comes in and he at, let's see, 6 a.m. here, had his breakfast. So his pH went from a 7 to a neutral, down to a 4, 4.5, and then back up again. So that buffering takes about 20 to 30 minutes for your saliva to do its thing, to bring that pH from an acidic back to a neutral. Now imagine this client is eating multiple snacks and multiple meals. So you see this acid attack continue to happen throughout an entire day. So it's important for us to really determine what foods our clients are eating so that we can figure out where is this pH coming from. So like I said, at this point, enamel and dentin starts to demineralize at 5.5. That drop is typically seen around meal times. So we're going to take a look at this alkalinity chart, and I really like this. It's from fridgecheck.com for those of you that want to use this as part of your nutritional counseling. You'll see a series of things that your clients are probably ingesting or drinking. So you can type in different products. I think you can even scan barcodes, and it can tell you what the pH of certain things are. So I really found it interesting that, if you take a look at French fries, for example, is a pH of 3. And then coffee and tea is a pH of 5. Popcorn is a pH of 4. So this really astonished me when I first saw it, particularly because I'm a coffee lover. And I used to sip on coffee for the better part of the morning. And I know most of you hygienists, you get to the office and you don't really have a whole lot of time before prepping your room and checking your charts. So you're probably doing the same thing as me, sipping on your coffee and your tea all day. So I found this interesting because I was wondering why I started to develop caries later in life. So I had 3 cavities between the ages of 21 and 23, and I wasn't sure why. Well, that's when I graduated dental hygiene school and started working in private practice. So I'm going to ask you what you think. I'm going to post on the left-hand side 3 things, and I want you to guess what the pH is. You don't have to write it down in the chat box. You can kind of mental note it or write it on a piece of paper. So we're going to play this little game. So I want you all to guess and think, what do you think the pH of Coca-Cola is? Now it's not going to be on the chart there, but you just take a guess. So you're probably right thinking that it was an acidic base, right? So it's 2.3 on the acid-forming food alkalinity chart. So you won't even see it on the chart. If anything, it's off the chart but on the wrong side. So we all kind of knew that Coca-Cola is an acidic. We've heard all of the negative connotations about it. So what do you think about Dasani water? What do you think the pH of Dasani water is? Well, you're probably just as surprised as I was when I read that Dasani water was actually a pH of 4. And there was a great article written about a golfer who was diagnosed with gout, and he had cramps, lots of heartburn, and he would drink almost a gallon of water per day. And they figured out that by testing the water that he was drinking filtered Dasani water. And it turned out that because of this constant acidic attack, it was not only affecting his mouth, but it was affecting his whole body. What about cranberry juice? What do you think the pH of cranberry juice is? Well, it turns out it's 2.3. So clearly pH doesn't know the difference between Coca-Cola and cranberry juice. It doesn't know the nutritional value. And I found this interesting too because I had a patient who was a yoga teacher. And she didn't quite understand why she was getting decay. She eats relatively healthy and all she drinks is water, tea, and cranberry juice. So it turned out that her tea and her cranberry juice were really attributing to having a low pH in the mouth. So I really urge you to use this resource. And it really will help you with your patients.
Great. So we're to our first poll question. And let me just grab the right one here. There we go. So, how often do you take the elements of dental decay into consideration when conducting your dental hygiene diagnosis? So just give everybody a few minutes. Just click the radio button to the left of the question, answer that you wish to select, and we'll show everybody the results in just about 10 seconds. Okay, I think most people have weighed in on this, so we'll just broadcast the results and you can see what your peers are saying. So the 65% of you say that you do this for every client and patient. And there's about a third of you who say that you're only doing this routinely for clients with significant decay.
Well, that's a great number. 65% doing it with every client and patient. That's really great. I really like to see that. So that's wonderful. So now at this point, we're going to really wonder, like, what are we learning here? What's all of this information for? How do we use it? And what's the point of it all? Well, it's important for us to really focus on prevention as dental hygienists. And we're really integral in the overall health of our clients and our patients. It's not just about their mouths. It's also about their overall health. And we know that that head is connected to the rest of the body. And it's important for us to kind of treat it all together. So we're really important for our patients. And really, we're the biggest advocate for their oral health. So it pains me to see things go south for my clients. And I truly feel that we make a huge difference in their health and well-being. So really want to focus on prevention, creating what I like to call a prevention plan as opposed to a treatment plan. arresting decay, remineralizing, using fluoride technologies to the greatest of its capabilities for our clients. I like to outline these 5 do's and don'ts. Do's and don'ts of remineralization. The first do or don't is don't poke it. Using your very sharp and pointy explorers really doesn't help the lesion. It makes it worse. Often we poke it and we try to achieve what we call a stick. Doc, I found a stick on tooth number 27, occlusal, I think it's decay. But what we're actually doing here is breaking the surface of what potentially could be arrested decay. We're allowing that transfer of bacteria to continue, and oftentimes it's increasing exponentially. Don't wait and watch. Let's do something about it. If it's time to repair it, then let's repair it. But if we wait and we watch, often that's just supervised neglect. I know that 6 months from now, 3 months from now, when our client comes back with what we think might be a cavity or the beginnings of a cavity, oftentimes it gets worse before it gets better if we're not intervening and doing something. If we really aren't ready to restore, let's put in place an action plan to remineralize or arrest the lesion. Give ourselves something that we can assist our clients in making their mouths healthier and not just waiting for things to get worse. Don't forget saliva. Saliva gives you great indication on what's happening in the mouth and in the body. Is the salivary flow rate low? Do we suffer from dry mouth for various reasons? What is the bacterial presence in the mouth? Is there a pH? There are often tests that we can do, not just checking for pH, but there are often tests that we can do checking for bacterial presence to figure out if it's a bacterial issue. Do use products containing fluoride, calcium, and phosphate. Those are the 3 major main components for remineralization. So really look at the labels of the things that we're using in our practice to figure out, are we giving our patients what's best for their teeth and all of the nutrients required for remineralization. And do provide nutritional counseling. Often it's one of the biggest causes for caries. After all, caries is a bacterial infection, right? An abundance of bacteria that's multiplying and that's affecting our teeth. So let's try cutting it off from the source and figuring out through our nutritional counseling, where is this sugar coming from and how is the bacteria breaking it down so quickly. Enamel is constantly demineralizing and remineralizing. Thinking back to that chart with the exposure of food, right? We notice that as we eat, our mouth goes from a neutral to an acid. Then our saliva buffers and brings it back from an acid to a neutral. And the cycle continues, right? So demineralization begins on a small scale on the surface of the enamel and the dentin. The demineralization is normally isolated underneath plaque and deposits on the tooth that may or may not have hardened into tartar, calculus as we know it. The longer plaque remains on the tooth, the more acidic it becomes, and the more tenacious it becomes. Plaque starts to turn into calculus in as little as 12 hours. And I'm sure we've all seen those clients that have that really sticky, tenacious plaque at the gingival third of crown lesions on root surfaces. So we can definitely see that and put it into common practicality. So when we talk about demineralization, it's when sugars and other fermentable carbohydrates reach that bacteria and form acid, which starts to dissolve the enamel, starts to demineralize the enamel. These early carious lesions occur due to that loss of calcium and phosphate, those essential nutrients in the tooth. So you can see that going from the photo on the left to the photo in the middle, where the sugars start to turn that plaque acidic, so you'll see it turns pink, and then calcium and phosphate is leaching out of the tooth. So at that point, we need to make things better. We need to remineralize. So how do we remineralize? Well, when sugar consumption ceases, saliva can then wash away the sugar and buffer the acid. Obviously, we need to assist it with plaque removal as well. The calcium and phosphate, again, can do their thing, enter the tooth, and then that process can process strongly to facilitate the fluorides from helping the tooth remineralize. The calcium and phosphate together form hydroxyapatite. That's what forms on the tooth. So let's envision we all win the lottery. We all have our lotteries in our provinces and nationally. And one day we're going to win the lottery and we're going to build that $1 million home somewhere overlooking a beautiful view. For my East Coasters and my West Coasters, you guys have the most beautiful views. So I'm going to probably pick up and leave Toronto and come to you. But those houses are likely going to require some bricks of some sort, right? So let's imagine the bricks are made up of calcium and phosphate. That's what those bricks are made up of. When they're together, they form what's called hydroxyapatite, what I just mentioned, which is what a tooth is made up of. The walls can't only be made of bricks, right? They wouldn't be very strong. They need something to bind them together. They need a cement to hold them together. And that's where fluoride comes in. Fluoride is like the cement that holds calcium and phosphate together. The three of them together make fluorapatite. So if you don't have the fluoride, you have hydroxyapatite. If you have the fluoride, it's called fluorapatite. So we really need to evaluate what materials we're using and ask yourself these questions. Is it the best treatment for my client, first of all? Does this intervention provide the best outcome? Do our materials give the tooth what the tooth needs, not only to survive, but to thrive in a healthy environment? So do our products contain the things that the tooth needs? Does it have calcium, phosphate, and fluoride? So I want you guys to put that on your checklist for what to do tomorrow or Monday morning to check what you're using and does it give the tooth what it needs to get back to healthy. Now, based on the ADA's recommendation, we can see that young adults and those over the age of 6 are recommended to have 2.26% fluoride varnish at least every 3 to 6 months, or 1.23% fluoride gel for 4 minutes at least every 3 to 6 months. Now, I don't know about you, but I can barely get a 6-year-old to give me their compliance for 1 minute, let alone have a tray full of foam and gel in their mouths for 4 minutes. So that treatment plan wouldn't last too long for me. If you guys have techniques on how you can get a 6-year-old or a 5-year-old to comply for 4 minutes with fluoride gel, please let me know. So I've kind of said no to the 1.23% fluoride gel, and I've stuck to the 2.26 fluoride varnish because, you know, I'm finding that's a preferred method. I know it's the only one that I currently use in my practice. So it's really highlighted as the preferred method there. And if you can look below there, you can see that that's also highlighted as an indication for those over the age of 18 as well. So it's not a matter of age, it's a matter of a risk factor in determining what the risk factors are, and then going from there with our treatment modifications. So as we review the methods of delivery, let's take a look at the strengths that are available. The green products are the over-the-counter products, and that's what we're advising our clients to be using at home. Very little fluoride in comparison to professionally applied products. So if we take a look at the in-office products, which are on the bottom highlighted in kind of a teal color, you can see that the most effective varnishes are containing about 22,600 parts per million of fluoride. So I really enjoyed the quote from Dimensions of Dental Hygiene in their March edition, and it stated that fluoride varnishes is becoming the most commonly used fluoride product in dental offices because of the evidence supporting its effectiveness, ease of use, patient acceptance, application time, and safety. So it really warmed my heart that, you know, hygienists are not only trying to be more effective and support our clients for having a better experience, but it's easier for us to use. So we're working a little bit smarter and not as much harder. So I teach at a dental hygiene school in Toronto, and I really like using the who, what, where, when, and how method with my students. And I see some of my student names in the participants here, so welcome Oxford students. So nice to have you guys here. On a school night, I know I'll see you guys in clinic tomorrow. But it really helps me remember things, and that was kind of my learning style too, outlining key points. So I've included that method here for you today. So you probably saw that in the microbacteria slide, or the microbiology slides. So what we're going to talk about now is a couple of treatment options for us. So who are we going to talk about now? It's 5% sodium fluoride white varnish. Called Vanish Varnish. And what does it do? Well, it's a slow release of fluoride. It absorbs onto the mineral surface and protects against that dissolution we talked about when the pH gets below 5.5. It contains a tricalcium phosphate. So that's a big fancy word that we're going to discuss in the next slide, but tricalcium phosphate is a main ingredient in here, which will be discussed, like I said, on the next slide. But what this does is as you place the, as you apply the Vanish Varnish onto the teeth, it's actually a salivary stimulated contact, so it hardens on placement with saliva, and it migrates into tooth surfaces quite slowly. So you don't have to worry specifically about placing it everywhere because it does have that contact migration. It releases over a 24-hour period, and it's wonderful to see that it's got a high concentration of parts per million here. It contains naturally found xylitol, and it's supplied in unidoses. So it's also available in 3 flavors, which is great. So TCP, or functionalized tricalcium phosphate. So tricalcium phosphate is something that I'd really like us to focus on, and let's take a step back to talk about it. So what we know is that the tooth will need calcium, phosphate, and fluoride to remineralize, right? So I'm not a chemist, and I had a really tough time in chemistry class in grade 12, and I remember my grade 12 chemistry teacher, Mr. Flegel, say, you know, it's not as easy as just mixing things together. You got to figure out why they're doing what they're doing. So this is a perfect example of chemistry being tricky. So when we have calcium and fluoride together, they don't work separately anymore. So once you put them together, calcium and fluoride no longer do what calcium and fluoride do best on their own. So they form together, they bind together. Calcium is a positively charged ion, fluoride is a negatively charged ion. So when they combine, they form calcium fluoride. Sounds great, right? Well, not really, because when they bind together, fluoride becomes less effective. It almost becomes useless. It's not as effective in preventing tooth decay, that's for sure. So to make things react independently, a calcium phosphate is milled and coated with an organic material to protect fluoride. So calcium and phosphate are then protected by this organic coating, which makes it functionalized to allow fluoride to do its own thing on its own and not be bullied around by milling all of these things together. So it allows fluoride and calcium to kind of coexist, and it gives the tooth the highest concentration of both calcium, fluoride, and phosphate. So it's kind of like a triple action. Application of Vanish Varnish. So I want us to take a peek here at this video. It's a quick refresher of how Vanish Varnish goes on the dentition. I'll probably get a lot of questions after about how it looks and the appearance, so you'll be able to see those images here in this video, but it definitely demonstrates the correct application, and I want us to take a minute and jot down a couple of notes about the application of Vanish Varnish.
Prior to application of Vanish 5% sodium fluoride white varnish, treatment area should minimally be toothbrush clean. A prophylaxis is not required. Peel the foil pouch open to expose the Vanish white varnish unit dose package and applicator brush. Open the unit dose package and dispense the entire content onto the application guide provided. Use the applicator brush to thoroughly mix the varnish, as components can separate during storage. Refer to dosage guidelines provided on the instructions for use to determine amount of varnish to apply. Apply Vanish white varnish evenly in a thin layer over treatment area. For larger surface areas, apply Vanish white varnish in sweeping horizontal brush strokes across multiple teeth. After application, instruct the patient to close his or her mouth to set the varnish. No rinsing or suctioning is required. Saliva quickly and uniformly sets Vanish white varnish onto tooth surfaces. Varnish beneath the set surface layer will continue to flow from treated to untreated surface areas for at least 4 hours.
So that's wonderful. I really like kind of doing a little refresher when I'm haven't done a varnish treatment in a little while, just to make sure that I'm doing it effectively, I'm doing it right, and I really like that sweeping motion. So I use that thin to win almost analogy. So a thin coating of Vanish varnish over the teeth from posterior to anterior is the correct kind of application, and also it provides the most effective treatment for our clients. So I really want us to remember that all of this is a treatment, right? It's just like any other treatment, and I do urge us to take all of the methods that we're using in private practice and really think about the why. Why are we using these treatments for our clients, and what is the ultimate goal that we want to achieve? So I want us to talk about ClinPro for a minute. ClinPro, some of you may have already seen, some of you may already use it in your practice. I brush my teeth with it, so it's a wonderful product to use, and yes, it comes in a tube, but it's not just a toothpaste. So don't judge a book by its cover and say that it's the run-of-the-mill toothpaste, because it's not. So it's a treatment in a tube, which is what I like to tell my clients. And it comes with the same technology that comes with our fluoride varnish that we were just discussing, the Vanish varnish. So it has the same tricalcium phosphate ingredient. And ClinPro has 5,000 parts per million fluoride. And like I said, it contains that same tricalcium phosphate technology that we just discussed. So this tube itself should last about 6 months, and that's ideal for clients that are at moderate to high risk. In our practice, we've incorporated this as part of our caries assessment tools in our treatment. We've also included this as part of our orthodontic treatment. So for those clients that have fixed orthodontics, brackets, Invisalign attachments, it might be a little bit more difficult to remove all plaque between meals specifically. So by having a higher concentration in the tricalcium phosphate, we get a slower release of fluoride throughout the mouth, so it helps us prevent those white spot lesions from forming, and if they do form, then it helps us remineralize the tooth so that when we remove the brackets, it reduces those areas on the tooth. Now for those immunocompromised clients, because we know we all have them, they suffer from xerostomia, we've provided them with this 100% xylitol mint. It's called a TheraMint. It's great for a substitute for those clients that are chewing gum. Maybe they're not as educated. They don't understand that chewing gum constantly can really destroy soft tissues, hard tissues, jaw joint issues, muscular issues. So chewing gum poses a lot of different concerns for muscular dysfunction, head and neck pain. But TheraMints are great because they come in 2 different flavors, so it suits for those that like mint and those that like a more fruity flavor. But it provides that 100% pure xylitol. And as we know, that's a natural sugar, and it's a natural alcohol sugar that bacteria does not break down into an acidic. So this basic amino acid in ammonia and saliva, it helps reduce the pH back to a neutral. So it raises pH from an acidic back to a pH of neutral. And it's great to use between meals, after meals, 2 to 5 times a day, snacks. For those clients that are really a high risk, they might end up using them more often. So what this also does is it inhibits that bacterial metabolism. There's less plaque that's formed, increases salivary flow, allows the saliva to do its buffering thing. And again, when pH is above 7, that calcium and phosphate salts in the saliva start to move into those parts where the enamel is weak, and it really assists in remineralizing the tooth. I really like the buffering action that it does for those clients that have dry mouth.
We're doing our second polling question right now. And again, we'll give everybody some time to make your choice, and we will show everybody the results in just a few minutes. So based on what we've reviewed thus far, when recommending caries prevention strategies, do you feel you are offering multiple treatment options? So give everyone about 5 more seconds here to make your choice. So most of you, about half of you, are saying that up till now you have only been recommending over-the-counter toothpaste with fluoride to your clients. So we're, even more than 50% now. So I'm sure that we're all very interested in the information that you're sharing today, Irene. And Irene, maybe you have your phone on, your microphone on mute or something, because we're not hearing you.
You're right, I did. You're right. What a newbie, right? Sorry, everyone. So as I was just saying, the Caries assessment method, or the CAMBRA method that we're going to be using, is a series of forms and questions that you fill out with your client, or your client can fill them out on their own if you trust their answers. And what these forms will do, it'll assist us in figuring out what their risk factors are. So I'm not going to go over all of the questions with you today, but these are just a few things that you'll find on these forms. The links will be provided for you to download them, print them, and bring them to your office with you. But it's important to determine each client's individual risk factors, because there's no such thing as a one-stop shop or a one-size-fits-all when it comes to dental disease or dental caries process. So I want you to ask yourself and your client the question, has there been any decay within the last 12 months? How is the oral hygiene? Is there poor oral hygiene or good oral hygiene? That might not be a great indication, but it might give us an idea of what's going on, because there are clients that have great oral hygiene but still present with decay. So what could that tell us? Well, it probably will tell us something, maybe their food. Maybe they have a high intake of sugars constantly. Maybe they have a lot of acidic attacks. Maybe they're snacking. Or what about their beverages? What about dry mouth? Are they taking any medications, any radiation therapies, or is it disease-induced? Is it caused by an underlying condition? Is there drug or alcohol use? Are they in active orthodontic treatment? Or is there an eating disorder of some sort? So these are all questions that you'll see on this CAMBRA method of determining risk factors. So there's two different forms that you can download from two different places. So there's the CDA, the Canadian Dental Association, that offers these two forms, one from the ages of 0 to 5 and one for over the age of 6. And then there's the ADA that also provides this color-coded. So you'll find that you'll answer questions yes or no, and ultimately you'll determine what the risk of your client is based on these correct answers here. So at that point, you figure out what your treatment modifications are. So this is the AAPD that gives us guidelines based on these caries risk assessments. What are we noticing? So let's say we've gone through all of our documentation. We figured out that we have a client. Our client is a young person between the age of 3 and 5, and we figured out that they're at low risk. So we've determined that our client that is at low risk, what are we going to do? So our diagnostics run with, recall exams, taking bite wings and baseline measurements, and then we're going to go into our interventions. So by adding interventions, we're really going to focus on brushing, making sure that our teeth are nice and clean, and using fluoridated toothpaste, because our client is, after all, at low risk. What if we have a client that's at moderate risk? And what if our parent is really engaged? So our parent is really engaged to prevent this disease process from furthering. Maybe we've had 1 or 2 cavities in the past. So what are we going to do at this point? It's important for us to really figure out whether we have a parent engagement or parent non-engagement, because that will really help us determine what type of treatment modifications we can give our clients to take home with them. So at this point, we'll figure out, brushing twice a day, fluoridated toothpaste, possibly incorporating some supplements, and professionally applied topical. So at that point, when we go to our high-risk candidates where our parents are not engaged, we get to the most severe, I suppose, of the recommendations here, where we're brushing with 0.5% fluoridated toothpaste, obviously with caution, and then professionally applied treatments every 3 months. So again, if we think back to the professionally applied treatments every 3 months, imagine giving a 3 to 5-year-old a 4-minute fluoride gel. That might be pretty difficult, but it would be a lot more easier to handle by using a varnish that's a little bit more quicker to apply, as you all saw in the video. So we talked about the implementation of these strategies for 0 to 5 or 3 to 5 years old. So now let's take a look at someone over the age of 6. So we're going to look at the same classifications: low risk, moderate risk, high risk, whether we have engagement or non-engagement. And at this point, we're going to notice that these interventions are going to be similar, if not the same. The only difference is when we start considering diet. Are we going to be incorporating anything into the diet? So this is where xylitol comes in. When we have those young persons with high risk, whether their parents are engaged or not engaged, patient engaged, not engaged, we really want to consider maybe incorporating xylitol, which is where the Theraments would definitely pop in to assist with buffering that acid throughout the day.
And here is our third question. Make it a little bit easier, so bigger, so it's easier to read. Based on what we have discussed about the CAMBRA assessment method, do you feel that you previously assessed caries risk as comprehensively as we discussed today? So just go about 5 more seconds here, let everyone have an opportunity to make their selection. And it's interesting because the results, Irene, are similar to what we had in the first go-round. So about 40% of you are saying that you put a watch on potential cavities but don't classify prevention methods that we have been talking about today. But about almost half of people are using these methods in practice.
Wow, that's interesting. That's interesting. That's the same as earlier. So that's a great opportunity for us, right? A great opportunity for us to really try and focus on remineralization as opposed to just waiting and watching for something to get worse. So just a quick summary of today. So the dental disease process is dynamic. It's multifactorial. And on many considerations, it's something for us that we're able to prevent and something that we're able to remineralize. In an ongoing fight with microorganisms, it's important for us to utilize all of the tools for prevention and patient-client satisfaction and education. Education is a big part of being a dental hygienist and educating our clients on what we're seeing in the mouth. It's overall our responsibility as healthcare providers. I encourage you all to put on your caries thinking cap and look a little bit deeper onto what's happening intraorally. I know we do our initial assessment, intraoral, extraoral assessment, oral cancer screenings. So really take a look closer at what the biofilm looks like. Is it in these areas on the tooth that we recently discussed? Take a look at what it actually looks like and the consistency of it. I challenge you to rethink your current methods of prevention and really assess your client's needs. So focus on where we're going with our products and our practice and read the labels, definitely read the labels and make sure that it says that your client product is going to contain calcium, phosphate, and fluoride. And I really encourage you to use, your detailed patient-client analysis, and you can determine what the risk factors are. Because, like I said, it's not one size fits all. So that way we can appropriately implement prevention strategies. Where previously maybe our methods were wait and watch. 50% of us said, yeah, we wait and watch. So maybe we can take that wait and watch and implement a different strategy. Implement a let's try and prevent before we fill. So these references will be available to you all, I think within the next week or so. Will be online for you all to take a look at these references that were all used for creating this lecture today.
So thanks, Irene. This concludes the presentation portion of our webinar. And we now invite you to key in your questions in the question and answer pod, or question pod in the bottom half of the screen here. And we will answer as many of the questions as we can possibly get to in the time that we have remaining. So just as we get started, I want to ask one question. Do parents or clients complain about the look of their teeth after the varnish is applied? And I know one of the questions that came in earlier was, you know, that she's having difficulty with clients accepting the varnish. Do you have any suggestions about that?
Well, right, yeah, so I've had this question asked before, and I know that in the past certain varnishes were more of a yellow color to them. Vanish varnish is a white, so it's nearly virtually invisible on the tooth. It also has to do with common misconceptions. Maybe the last person that applied the varnish on our client's teeth didn't do it the right way. Maybe they globbed it on and there was too much and it felt really sticky. Maybe it just wasn't done right. So like I said, really encourage your clients to try a new product or try a new method or new technique, and I encourage you guys to try that technique when placing Vanish varnish. So the one thing that I really noticed is the color. So when you have a clear or white varnish, like the Vanish varnish, you don't notice it as much on the tooth. And the consistency of it when you place a thin sweeping layer, like in the video, again, it's not bulky, it's not heavy, and you don't notice on the tooth. So luckily for me, I've never had that problem. And for those of you that have had the problem, then I encourage you to try something that's a clear, like a Vanish varnish, and use a thin layer on the dentition.
Great. So one individual says that they've heard of or have experience, I'm not sure, but they're saying, asking about varnish clogging the suction of the tubing. Have you ever had that experience?
I haven't, because you don't need a suction with Vanish varnish. So the saliva sets the varnish to the teeth. So if you're removing all of the saliva, then you're unable to set it to the dentition. So what you want to do is you want to apply the upper portion, have your client close and swallow, and then you apply the lower dentition, so maxillary then mandibular, and then you have your client close, and that's what sets the varnish to the teeth. So I'm not quite sure what product you were using, but it shouldn't be globbed so much that it's going down to the posterior into the suction.
Okay. And a couple of people had asked this question earlier, and I responded to them. But for anybody else who was wondering, yes, you do put it on the lingual surface as well. It just wasn't shown in the video, but you do put the varnish everywhere.
Mm-hmm.
Where can you get ClinPro 5000 and Theramins? Which dental suppliers carry them? Do you know?
I'm not sure what province you are in. Maybe if whoever that person is can email me and let me know what province you're in, and I can tell you what company supplies to your province. It's made by 3M, so check who your local suppliers are, and online you can always call the 1-800 number on the 3M website as well. But if you want to shoot me an email, whoever that person is from whatever province, then I can find out for you.
Can you talk a little bit about recession and root surfaces and the application of varnish?
Wonderful. So it's similar as placing it on enamel. So as we know, root surfaces are a lot more porous. So it's actually in great favor of placing varnish on root surfaces to prevent root decay and remineralize decay on root surfaces. So there's no difference in application. You're just taking your brush and you're sweeping it across the cervical third, across the gingival margin. So you might find you have localized areas of recession. So there's no difference. You just kind of sweep it all the way across, and it acts in the same method as if it were with remineralization of enamel. So the calcium triphosphate will do exactly the same thing.
Great. How frequently can you reapply the fluoride varnish?
So I would say that this is a patient-client specific matter, and this is where risk assessment becomes really important, figuring out if we have a low, moderate, or high-risk client, and then, again, the age. So just based on the ADA recommendations, if you looked at I guess the third last slide, even someone that's at high risk, you wouldn't place it any more frequently than 3 months. So 3 months would be, I guess, the soonest after your last placement. So from 3 to 6 months, that's where the guidelines fall in for those that are at high risk, all the way down to moderate risk. So I wouldn't over apply. I would apply it in the dental office every 3 months, but then I would send them home with a treatment like the ClinPro 5000 so they can continue to remineralize on their own.
Okay. Can the varnish be applied under 3 years of age?
Yes. So again, client-specific, compliance-specific, but yes, it can be. So the indications on that chart are between 3 to 5. And there are some statistics and studies online that show that it can be placed on a child as young as having their first tooth. But again, you would have to consider that patient specific.
Right. I was involved in a project, Janice, where we did place fluoride varnish on children at high risk for developing decay. As young as, like, I think the youngest we had in the study was like 16 months, but that was just, that's, you know, when we were able to get a hold of them, kind of thing. So it was pretty easy to do, and yeah, and it happened that we were doing it in people's homes, and you don't need a lot of equipment. It was great. So.
Oh, that's wonderful. I had my doctor today tell me that she's doing a medical mission in Kenya. I did one a few years ago, and that's their main resource for prevention is doing fluoride treatments, specifically placing varnish treatments and of children for all ages. So I didn't include any of that in my data, but you definitely can find it all online.
Are there any contraindications to using the varnish product? Say that 5 times fast.
Yeah, so you definitely don't want to place it on open cavities, like large open decay. For those clients that are at low risk or decay-free and have fluoridated water, like I would consider that a contraindication because they technically don't need it.
What about medical contraindications? Is there any?
Yeah, so there has been something that's mentioned about pine nut allergy. So for those that have a pine nut allergy, to really consider whether this or have a product sensitivity test to see if pine nuts is an allergy. That could be a contraindication. And I've also read something once about those that have uncontrolled asthma and panic attacks, more like an ASA tube, ASA3 in the office that's kind of uncontrolled.
Okay, so a bunch of people are asking about application, and as mentioned earlier, you do put it on all of the tooth surfaces, the buccal, the lingual, and the occlusal surfaces, and it will then migrate interproximally as well, correct?
Absolutely. So, yeah, sweeping motion, posterior to anterior. I like to do from right side all the way to left side. And you do a couple of segments at a time. Consider it like a sextant. So sextant 1, sextant 2, sextant 3. You do all buccal surfaces. Then you come back on all occlusal surfaces, and then you do the same on lingual surfaces. The migration is about 3 millimeters in each direction of where it's being placed. So if you're placing it right on the gingival third, it will migrate to subgingival. If you're placing it to interproximal, it will migrate right to interproximal. It will migrate underneath crowns and bridges as well.
So a lot of people are asking about, do you need to dry the teeth before you place this?
No, so you don't want the mouth to be sopping wet, so you have your client open. If you notice that there's an abundance of saliva and they're over salivating, then I would probably just take a cotton roll or a piece of gauze and just swipe it all the way around. But typically, no, you wouldn't have to worry so much about contact with significant saliva, because if you think about it, saliva is what sets it too. So you don't want to be absolutely bone dry in their mouth if they don't have a drop of to set the varnish.
Yeah, and a lot of people are asking too about swallowing the excess, but really once it's set, they're not really swallowing it, correct?
No, it's not a viscous varnish. So it sticks to where you put it. There are lots of different varnishes that have been on the market for the last, I've been dental hygienist for 10 years, so I've seen and tried a lot of them, and some of them are just really viscous. This one is not viscous. So once it's on the tooth, it sticks to the tooth in a thin layer, and then you put your mouth, you close your mouth, your saliva will set it to the tooth. I kind of like to think of it like almost like a nail polish, right? It's a thin nail polish that goes over the teeth, and then it starts to set.
And do these products also help with sensitivity as well?
Well, yes and no. So if you're talking about dentinal hypersensitivity, then that's not something that we can kind of allege that it does. But if you think about it, you know, certain dental caries that are in early stages of dental decay that are able to be remineralized, some of those areas are sensitive to cold. So I would say, yeah, if it's remineralizing the tooth, then it's going to make the tooth healthier and probably less sensitive.
Somebody, I don't know if you're familiar with this product, I haven't heard of it before, but for the patient who refuses fluoride treatments, are products such as Happy Mouth, which is fluoride-free and xylitol-based, just as effective?
I am not familiar with Happy Mouth.
Okay.
Yeah, sorry.
Okay. Great question from Rachel. My dentist recommends application after the recare examination so use of the Explorer doesn't disrupt the varnish. Is this accurate?
Wonderful. I'm very happy to hear that. That's great. And it also, it makes the patient feel a little bit better. This is the last step, and then we're out of the office.
Mm-hmm. And lots of people asking about post-op instructions. So maybe can you just go over those one more time?
Yeah, absolutely. So post-op instructions, you want to avoid anything that's sticky and crunchy and hot. So your clients can eat right after as long as those foods are not sticky or crunchy or hot, like hot beverages or hot soups. So they can, have a piece of toast if they want, or some crackers that aren't, really sticky and really crunchy, like soft. Other than that, no brushing for 4 hours. That's the recommendation. If you can do overnight, so if it's the end of the day and they're not having anything to eat afterwards, and they can go until the first thing in the morning, that's ideal, but typically it's 4 hours. And that is it. Those are the only recommendations: sticky, crunchy, hot, and 4 hours.
And alcohol, right?
And alcohol, yes, alcohol. Thank you. Got you.
Hopefully the children aren't using that.
Yeah, 3-year-olds with alcohol, please.
So are there any milk ingredients in either the varnish or in the ClinPro 5000?
I don't believe so, but I don't want to say yes. Let me double check that. And will you get the email address of who asked that question?
Yeah, or we can just send it out in our email
Wonderful.
to everyone.
I'll write that down.
Or the person who wanted it can email you directly.
Perfect.
One or the other. We'll figure it out.
That's great.
I'm actually interested in that as well because I have a child with a dairy allergy.
Okay, so. That's great.
Great. So the presentation will be available to you as a resource within a week. So you'll have a PDF of the slides so you can use them for reference, and we'll make sure that we give you full-size page of the references so you can actually read them and be able to access them. But unfortunately, our time is gone, and we didn't get to everybody's question. I apologize, but it's really great interest in this presentation, and I think it's a topic that people are really super interested in, as witnessed by everybody's attendance tonight.
Wonderful.
So thank you. Thanks, Irene, for such a wonderful presentation, and for 3M for sponsoring it. It was fantastic. And so this concludes the presentation portion of our webinar, and I invite participants to, no, we already did the questions. So this concludes our webinar. On behalf of CDHA, I'd like to thank Irene for presenting today and 3M for sponsoring the webinar. So follow the link on the screen here, and you will be able to complete the webinar survey and the quiz in order to get your certificate of attendance. Note that you might have to log in again to access the webinar curriculum. If you're unable to take the survey and quiz at this time, you can access the webinar curriculum at your convenience on your profile at www.cdha.ca/profile. Please note that the quiz is designed to allow 20 users at a given time. So if you attempt to access it and cannot, allow about 15 minutes and try again, and the people that were currently using that system will have finished. Be sure to log on to the CDHA website for information on all of CDHA's live and on-demand webinars. Thanks so much for joining us, and have a great evening.
Thank you.